India and run the
Yeah,
session.
I understand. The same is in the UAE. We have 50 degrees today.
Yes, I understand. Okay. So let's start. We shall start the session. It's already 7 o'clock. So we shall start as per the process. So Faisal, please start. Thank you.
Yes,
Welcome, Professor Krishna.
so good evening, good afternoon, and good morning, everyone. A very warm welcome to Session 8 of the Global Advanced Certification Program on Strategic Research Collaboration and Communication for Emerging Researchers and the International Workshop Series, proudly organized by the Global Consortium of Global Health Actors, Leaders, and Thinkers, Global ALT, the Global Health Forum, the Global Brain and Mental Health Forum, and in collaboration with local delivery partners, Bangladesh Institute of Innovative Health Research. Today marks the session 8 of our international workshop and panel discussion series, which is already featured by eminent speakers from all over the world each weekend. So far, we have had a few preeminent and renowned speakers from top academic institutions in Africa, Australia, India, Malaysia, Singapore, and the USA. We are honored to bring you two powerful and timely panel discussions today, featuring renowned experts from the Middle East and North America. These sessions reflect the spirit of our series, Advancing Real-World Skills in Research, Advocacy, and Global Health Leadership. Today's panel will cover psychology for social impact, public health-based injury prevention, and integrated strategies for HIV prevention. We are once again joined by Professor Maheswar Satpathy, the CEO of Global ALT and Director at COE ECCPH India, who will be moderating both panels. Global Consortium of Global Health Actors, Leaders, and Thinkers, Global ALT, operates under this Global Health Leadership by Global South Initiative, a flagship project of the Global Health Forum. The consortium brings together global health experts, researchers, practitioners, and policymakers, especially from developing and underrepresented regions, to collaborate on transformative research that drives equity and systemic change in health. As of today, the Global Consortium is the largest dedicated professional consortium of global health, with more than 2,000 leaders from 170 plus countries who have applied to be members through a rigorous process of member selection and full documentation of members' credentials. Our vision is reimagining global health leadership by the Global South, decolonizing global health. We are the global alternative. BIIHR is a non-profit student-led research organization that promotes research culture among students and early career researchers. Nearly 50 students are working in research and managerial roles. BIHR actively conducts public health research and regularly organizes training, workshops, and seminars to build capacity among emerging scholars. Some ground rules for our session participants. Please remain muted unless you have some questions. You can drop your questions into the Q&A. Our moderator will keep the questions in the Q&A section of our panel. And your attendance will be tracked from start to end. And also we will share an attendance form during the session, which you all have to fill up. And maintain a respectful and inclusive environment throughout. Chat box will be monitored regularly. Any unnecessary, repetitive, disrespectful, unprofessional, and hateful comment in the chat box or Q&A targeted towards anyone will be deleted and such members will be removed. So our first panel discussion is Public Health Approach to Injury Prevention Experience from the UAE. Joining us now, Professor Michel Grivna, Professor and Director, Institute of Public Health, College of Medicine and Health Sciences, United Arab Emirates University. And once again, this session will be moderated by Professor Maheswar Satpathy, who is a world-renowned leader in One Health, global health, planetary health, brain and mental health. He is a much sought-after expert in epidemiology, health emergencies and implementation science, and health innovation using the power of emerging and futuristic technologies such as AI, ML, LLM, and generative AI, and geospatial information system science and technologies, geographic information systems, GIS, and remote sensing. He builds on his core areas of expertise in cognitive and computational neuroscience, psychology, and global health to benefit humanity. His sustained engagement with UN Sustainable Development Goals and ethics in the broader area of public policy has led to holistic societal transformations in various LMICs. Professor Satpathy has a humble age index of 79 and cumulative citations over 155,000 plus. He has published extensively 285 plus peer-reviewed scientific articles and book chapters in journals of global repute, notably in Nature, Science, The Lancet, NEJM, JAMA, PMJ, Circulation, PLOS, and many more, and has offered keynotes and invited talks at more than 200 top international conferences and global congresses in the past 20 years. He has an impressive all-metric score of 68,255, exemplifying the large-scale social impact driven by their work. Professor Satpathy is currently a research fellow at the Institute for Global Health and UCL Global Business School for Health of University College London, UK, and also is a substantive faculty member at Utkal University, Bhubaneswar, India. He is the director and lead of Center of Excellence in Environment, Climate Change and Public Health Policy, COE-ECC PHP, a joint initiative of Government of India and Odisha since 2023. In the past, he has occupied prestigious positions as research scientist at UNSW, Sydney, AIMS, New Delhi, and consultant clinical psychology and assistant professor at Army Hospital, RNR, New Delhi. He has held visiting researcherships, fellowships at University of Oxford and Columbia University in the city of New York. He was a global health consultant, Dalla Lana School of Public Health, University of Toronto between 2020 to 2023. Professor Satpathy is an established scholar engaged with planetary health and well-being, global health, mental health, transdisciplinary gender and sexuality studies, and critical development studies focused on sexual and reproductive health and rights, and politics and ethics of social justice, and aim to nurture peace and harmony in the world. Some of his concurrent research themes of interest cut across health, data, technology, development, and policy and law. These disparate clusters do interact and inform each other as they have constantly shaped his career as he has evolved over the years. He has a successful track record of over 20 years in designing, delivering, and evaluating global and national public health programs. His multifaceted engagements in Asia Pacific, Africa, and Europe, and clinical practice in India have contributed to my well-grounded perspective and expertise. His strong diplomatic skills and proven track record in developing strategic partnerships have helped form vital global collaborations enriching public health and mental health policies and initiatives. His multidisciplinary approach, integrating development policy with global health, has empowered teams to translate complex research into societal impact in LMICs. Professor Satpathy, may I invite you to introduce our esteemed speaker, Professor Michelle Gribna, and begin this important discussion, please.
Okay. Could I get a confirmation from you that you can hear me all right?
Yeah, we can hear you.
Okay. Thank you. Thank you, Faisal, for the generous introduction. So, this is my utmost honor and privilege to introduce Professor Michael Gribna. Professor Michael Gribna is the Director of Institute of Public Health at the College of Medicine and Health at United Arab Emirates University. He is also a consultant physician specializing in public health, holding an MD and PhD from Charles University in Prague, Czech Republic, and a Master of Public Health MPH from the Medical College of Virginia, Virginia Commonwealth University in USA. He is also a Fellow of the Faculty of the Public Health of Royal Colleges of Physicians, United Kingdom. Professor Gribna is a leading expert in injury control and safety promotion with research covering various topics including childhood and adolescent injuries, school safety, traffic safety, health promotion, public health workforce development, the global burden of diseases, and other critical public health issues. He is collaborating as a consultant with various public health and preventive medicine institutions in the United Arab Emirates and abroad, including the Department of Health, Abu Dhabi Public Health Center, and Dubai Health Authority. He played a leading role in the activities of the European Child Safety Alliance and the implementation of the WHO SAFE Community Program. He is currently a mentor of young scientists in the WHO Violence and Injury Prevention Mentorship Program. In October 2017, he received an International SAFE Community Distinguished Career Award and was honored among 100 expatriates for contributions to UAE society in 2018. Professor Grivna was listed among of the most cited scientists in public health in Stanford list for 2023 and 24 consecutively. He has an impressive H index of 40 and a cumulative citations over 29,000. He is a member of several scientific committees and associations, example, ASPR task forces, International Union for the Scientific Study of Population, that is IUSPP, and Association for Medical Education in Europe, that is AME, and European Public Health Association, UPHA, and International Epidemiological Association, IEA. So with this very humble and very generous small little introduction of Professor Michael Grivna, I would request Professor Grivna to kindly illuminate us with his profound wisdom and his 4 decades of experience in the field of global health and public health. So Professor Grivna, the floor is all yours. I look forward to this. Thank you.
Thank you so much. Thank you, Professor Satpathy, for a nice introduction and also for inviting me for giving this lecture. I will try to quickly share the screen and only let me know if you can see the slides now, if it is visible.
Yes, I can see the slide.
You can see, right? Okay, great. Excellent. I will close now the only, okay. I will only close the camera. Okay, excellent. So today my presentation will be about injury prevention. And before I will start, let me introduce UAE University. It is oldest university in the UAE, founded in 70s, and we already will reach 50 years anniversary. It is based in Al Ain. Al Ain is a very nice green city on the border with Oman. And not so far away from Dubai or Abu Dhabi. It is almost 1 hour driving. Now, my topic today is quite broad, so I will try to cover very shortly about the injuries definition. I will speak about the hidden metrics, some epidemiological approach to injuries, and also some shortly couple slides about intervention strategies. As it is already very well known that in public health, any intervention should be evidence-based. So we are trying first to define the problem, identify the risks, then develop some prevention strategies, and then to assure widespread adoption. It is cycle, so then we need to measure if this intervention was successful or not. So first, I will start somehow with definition, injury definition, and possibly maybe some of you already know that injury occurs if it is exposure to energy transfer, which our human body cannot tolerate. So our tissues, as you see, have some tolerance. If we will take, some soup, which is hot, but if it is too hot, then we can have the burn. If we are going to travel to some cold, for example, Alaska or Nepal, to some mountains, and will not take enough clothes, so then we can have frostbite. And of course, any type of energy transfer could cause the injury. Global Burden of Diseases Network a little bit expanded this definition to include also violence, interpersonal, war, conflict, and natural disasters. So this related to definition. I would like to stress some misconception that injury is not an accident. Many of the people are using the accident as synonym to injury, but definition of the accident completely different. So it is any unexpected event in our daily life. There is some picture, if you will spill the milk or coffee on the table, this is accident. If you will forget the keys when you are going to shop and you need to go back home to take the keys, this is accident. So some accident, unfortunately, they are leading to injuries, but not all of them. And there is some misleading connotation of unpredictability and unpreventability of the accident. This is why many of scientific journals, like here is example from BMJ, but it is also Lancet or New England Journal of Medicine, they are banning the word accident in the title. So if you are doing some research related to, for example, traffic crashes, and you will submit the article to BMJ, they will not accept it if you will not change the word accident. And it is again for this connotation of unpredictability, unpreventability, and injuries. They have some risk factors. This is why it is important to distinguish. Maybe more clear, it is from this injury spectrum, this concept which was introduced by World Health Organization. It is clear that in daily life we are exposed to some risks. And for example, we are walking on the stairs, so we could be exposed to the risk of fall. Maybe even if we will fall, maybe we will not be injured. If there will be not transfer of kinetic energy in the amount which really our body can tolerate, so then nothing happened. But unfortunately, for example, if it is older lady and with osteoporosis, so maybe she has a fracture, and even she could be brought to the hospital. So maybe she cannot work enough, like properly as before the injury. So this could lead to disability. Maybe in the hospital she will have the pulmonary embolism and she can die. So in this case, this exposure to death, it is this injury spectrum, and this very clear distinction between event or accident and injury. So some events are leading to injury or some accident, but not all of them. Now, if I'm asking the question, which is leading the question, is injury a public health problem? So, of course it is. And here is some example from USA mortality among the young population. So, injury, it is leading cause of death between one, in the developed country, between 1 and 45 years of age. So, it is quite challenging issue. Of course, here it is clear that, the infectious disease deaths related to infectious disease decreased. But, injuries are increasing slowly. And in this population, between 1 and 24, it is leading cause of death. In the UAE, it is even somehow bigger challenge, and worldwide injuries are fourth leading cause of death. It is around 10%. Some years it is 11, some 12. It depends if there is some war conflict, for example, or natural disaster like tsunami. So then proportion is increasing slightly. But here in the UAE, it is around 20%. Some years it is 22. This is example 17%. So it is second leading cause of death in the UAE. And the proportionally from injury deaths worldwide, traffic is 22%. So this is in the children, but it is very similar also in adults. And in UAE, we have a huge proportion, 63% of the children related to the injury are dying from traffic. Of course, there is drowning, falls, and some other issues, but traffic is quite challenging. And in the all population, all age group, it is 65%. So traffic-related injuries are major public health problem in the UAE. If we are focusing on the data sources, of course, the death mortality, it is only top of the iceberg, and here's injury pyramid. So it is based on the mortality reports, but we need some data also from these lower levels. In the UAE, we have the trauma registry based on hospitalization, and it is all trauma centers. If they are accredited, they have to have trauma registry. In the Abu Dhabi Emirate, we have also injury surveillance, but it is on the emergency emergency treatment, emergency room treatments. So it is a little bit lower, and we need to be aware all times what data source we are using, because, for example, in the hospitalization, the most often hospitalized injury is traffic related, but injury treated in the emergency room, it is falls. So always we should be aware. Of course, severity is very important to find out, so not all levels can give the answer about the severe injury, so it is really quite challenging. Household survey could, answer for prevalence of all injuries, but unfortunately, due to some cultural reasons, it is not so easy to do. So in our setting, it is not easy to do the community household surveys. Now, but it is still more complicated issue because, for example, if it is traffic-related injury, the data sources are very rich. So it could be from the police, from insurance company, from trauma centers. Even some of them, they are not in the statistics, they are going to the morgue. So there is in the death notification. So and still there are some activities related to the unifying of the information system, but still we don't have unified information system. And definition is very important. For example, definition of death related to the traffic is different by police than from the health sector. Police is defining the death related to traffic injury in the time span of 30 days from the traffic crash. But health related, it is even 2 years or whatever, the patient will stay in coma and after 2 years will die, so it will still count. So these are some discrepancies in the statistics from the different sources. Now, injuries, we are dividing to the two major parts by the intention. So unintentional or accidental injuries, there are a couple of the examples, traffic injuries, fall, drowning, burns, fires, poisoning, and some other. And intentional injuries. Intentional, it is violence related, and it is intention to harm somebody. And there are different categories: interpersonal, self-harm, like abuse of drugs and alcohol in the statistics of intentional injuries, war, and so on. Of course, even some categories in the unintentional injuries, like traffic related or poisoning or burn, could be also intentional. So sometimes it is very difficult to establish intent in the injury, especially for the proper death notification. Now, consequences of injuries, it is quite important issue to assess, for example, health consequences, and there are many of the post-traumatic changes, especially for the children. If the fracture is in the growing part of the bone, then could lead to disturbances in somatic development, long-lasting pain, and so on. There are psychosocial consequences, extreme stress related to the injury. Many of the serious injuries are leading to post-traumatic stress disorders in the childhood. They are part of the adverse childhood experiences, and they could lead to many mental health consequences in the adulthood. Of course, disruption of social inclusion, scars, for example, and long-term hospitalization, emotional deprivation, and so on. There are also important economical consequences, and this could be direct or indirect. Direct, it is any medical or rehabilitation costs related to the injury, but also indirect are quite large. World Health Organization estimates that, for example, road crashes cost most countries approximately 3% of GDP. So it is quite a large part of GDP injury are taken. So it is really quite large cost. If you are moving to the second, on the public health cycle, so it is identify risk and protective factors. So there are different factors affecting injury patterns. From degree of motorization, here we have substantial growth of the population in the United Arab Emirates. When I arrived 22 years ago, it was only 2.5 million. Now we are around 10 million of population. So it is quite a very fast growth of the population, and it is leading also or associated with the growth of motorization. But there are other like economical disparities, housing design, consumer safety, quality of ambulance system and trauma system, health facilities, how trained they are, staff, and of course the weather and local ecology. It is huge influence of the injury patterns. The table in the corner is showing mortality and intentional injury death rates, a comparison between the low and middle income country and high income countries. And there is a very important socio-economic gradient, as you see. It is like, in almost all categories here is 8 times in drowning, 8 times in fire and burns, road traffic, it is double, and so on. So it is like quite, socioeconomic gradient is quite high. Now, for unintentional injuries in children, there are, additional risks related to psychological and motoric development. For example, in children, the development of binocular stereoscopic vision is still not matured with the newborn. Right? So there is some like sensoric development is going through the early childhood. So children, small children, they have much narrower visual field, or they have the much longer time of reaction, recognition of the size and force of motion. So, for example, if the small child, 2 years old child, is crossing the street, they think that the car is moving slowlier and it is more far away. And also, for example, they have the limited hearing to the backside. So maybe mother is calling, the stop, don't cross the street, but maybe he cannot even hear, or she. There are factors related to supervision and care and environmental factors, and also product-related factors, like, for example, baby walker, which is very often used in the UAE as toy and is incredibly dangerous. So I can, discuss later about this. Here is an example from the traffic around the school area in Alliance, this picture, and you see that the boy who is crossing the street, maybe even driver cannot see him because, the vehicle, front vehicle is so high, so it is quite limiting. So there are like different risk factors for children. Now, to study risk factors, we are using very often epidemiological triangle or epidemiological model, which is like classic epidemiological triad from the personal human factors, environmental factors, and vehicle or agent factors, which is in infectious disease, it is agent and vector, which are very important. Here is an example from the traffic. But I would like to mention also Dr. William Hedden. Dr. William Hedden, he was physician and also engineer. He was focusing on the traffic safety in the USA. And he published different very important articles. One is this one, it is Advanced in Epidemiology. So he was using this epidemiological concept for traffic safety, and he developed so-called Hedden metrics. And in Hedden metrics, he combined these epidemiological triangle factors with the time factors of the crash. So pre-event or pre-crash, during the crash, and post-event. In fact, this Hedden metrics is very useful to study risk factors for any type of injuries. We are using Hedden metrics, but also for intervention, for establishing some prevention or intervention. Here is some example of Hedden metrics for traffic-related injuries. And as you see here, personal factors could be like, police enforcement, also education, driver education, restraint use. It is during the event, it is very important, but it is also technology, so it is agent factor. And post-event, access to medics, first aid, rescue facilities, and so on. So Hedden metrics is incredibly useful for the studying risk factors, but also for prevention. Now, what I would like to stop a little bit about the causal factors for injuries, they are not so well defined, and we need to be very careful when we are studying the risk factors. And I will give you 2 examples. Here is an example for some man who is walking on the stairs and is falling. Usually, we are blaming the victim in some way. So we are saying, okay, so maybe he was drunk, maybe he was tired, maybe he was not aware that they are very, challenging the stairs or whatever. So usually we are not focusing too much on underlying cause. And here in this case, underlying cause, it could be very unsafe design of the stairs. The same is in pedestrian crossing. Many times when there is some like crash between the car and pedestrian, for example, child, so police is coming, investigating, and they are blaming either driver or the pedestrian for this injury. And maybe there is underlying cause, which is the pedestrian crossing is not safe. Maybe there was not even pedestrian crossing. So for this epidemiological approach, it's very important to find out underlying cause of these injuries. So this is very important. Now, it is very important to do some epidemiological and behavioral studies, because many times I was speaking about the mortality, right? So it is secondary data, but we need to find out also behavioral factors and why the people are doing, or why they are taking the risk, or why they are not taking the precautions like using seatbelts, for example. And this is why it is so important, the collaboration between government and academia. Academia usually have the experience to provide this, primary data, to do epidemiological studies, environmental studies, and so on, and to help to properly identify the risks. Now, if we are moving to the third part, and it is develop and test prevention strategies. I need to tell that it is, and it is very well known also from the health promotion, right, that the knowledge is not sufficient to change behavior. We can note that, for example, the seat belts are decreasing the risk of death during the traffic crash, but maybe we are not using the seat belts because we don't have proper attitude. So to change behavior, it is quite complex issue, and we have the different theories of the changing the behavior. And in the health promotion, they are very well known, but it is very complex issue. I would like to show you some results from the study which was done in Canada by Louis Francescuti. Professor Louis Francescuti is an emergency physician, but he was an incredible scientist in Alberta, and he was a couple of years even president of Royal Society of Physicians of Canada. And his study, he was doing quite interesting study showing that despite that there is efficiency of different, prevention strategies like seat belts, child safety restraint, bicycle helmets, or tap water regulators, for example, quite high, right? But the use of level use is very low in Canada, or in Alberta, at least he was doing the study. Only 5% of bicyclists were using bicycle helmets, and only 5% of the household were using tap water regulators. So there is the great gap between the possibilities of prevention and efficiency of prevention strategies, but of the level of the use. The professor, Andrea Gilland, she's from Johns Hopkins University, she was writing this very interesting article, and she was mentioning that there is a need for active approach to passive protection. There is very important to raise awareness about this passive protection, and to even to educate decision makers, health workers, and population about the possibilities of injury prevention, especially passive protection, that there exist, and we need to use them. Now, what are the challenges in some intervention and injury prevention in the UAE? We have quite slow adoption of efficient interventions from the abroad. Often we have missing piloting or impact and outcome evaluations of the interventions. Many times there are awareness campaigns, but not assessing properly the impact or outcome. Experiences from other countries, it is very difficult to transfer to the UAE setting. Possibly there are cultural differences. We have multi-ethnic population. We have almost 180 different nationalities living in the UAE. There are different, language barriers. And also, what is very important, it is some barrier for the prevention, and it is this traditional views on causality. Many people are thinking that the injury occurs because it is destiny of the person, or even evil eye, or genes. So when I arrived, taxi driver had this, evil eye protector in the car, and he was telling me that I don't need to use the seat belt. So this is quite still embedded in the culture, and still it is barrier for the proper injury prevention. And I will give you some examples from the studies. We are doing some very interesting study on the traffic-related injuries. And here in the UAE, it is very popular off-road driving, quadribikes and SUVs. This was hospitalized traffic-related injuries who were treated in the hospital. So quite big proportion of these injuries are from the off-road. What is also very interesting that there are many of the rollovers. So, and the 37% of the traffic crashes were rollover crashes. And it is because the SUVs are incredibly popular. They are more driven than sedan cars. Sedan cars has a center of gravity lower to the ground, and they don't tend to roll over so easy. But SUVs, they have higher center of gravity, and they tend to roll over during the traffic crash. So this is why it is so important to use the seat belt or car restraints in the car for the kids, because otherwise, the vehicle occupants could be ejected. So we have many of the ejections and injured, the passengers injured in the ejection. Another example is falls from windows, and this, the somehow barriers or culture differences. I found the book of accidents, which was published in 1813 in USA, and the fall from windows by the child, it was already written there, and it's like quite interesting to read, right? In this book, what feelings of pity runs through us. We behold the situation of this poor girl. In another moment, she may be dashed up on the rocky pavement below and picked by her affectionate parents and course. What horror is depicted on her countenance. So it was in 1830 described, right? In fact, in New York, the first very efficient injury prevention campaign was Children Cannot Fly. And it was in 70s. There were, a lot of falls from the windows, especially through the hot summer. And among those population who were like really in social class, who could not afford to buy air conditioning. So the public health department started the campaign, and they did the home visit and issued window guards free of charge and installed the window guards. So, and they decreased reported falls decline by 50%. So we found that there are also falls here in the UAE, so we wanted to study with a group of students. We did quite interesting study, and in 10 years, we're doing newspaper clipping study, because the data you cannot find in death notification, you cannot find in police records, and you cannot find in the health information system. So we relied on the newspaper clippings, but we were checking all the newspapers in the UAE in Arabic and also in the English. And we found 81 cases, and those like from really quite high. And as you see, half is from windows, half of balcony. But what is really striking, it is very small kids, small age groups, and 54% of these kids were supervised. There was some adult or older siblings or some family member in the household when it happened. So it is really quite challenging issue. And of course, the municipality started to intervene. There were even the health authorities started to do the awareness campaign. Municipalities started to raise this issue, and owners of apartment buildings now they need to do the awareness of the balcony and window safety among the families. They raised even the guards on the balconies from 80 centimeters to 110, and using proper safety features. So there were some recommendations that, lock and open windows, keep furniture away, safety windows guards, balconies, the bars on the balconies should be maximum 10 centimeters and only vertical, not horizontal, and so on, and the children should be supervised. Now, if we are moving to the number 4, and it is assure widespread adoption. And now, injury prevention, and there are many cost-effectiveness studies, showed that they are very cost-effective. So it is example for one study, which was in Europe, €1 spent on smoke alarm saved 69 euros in the consequences. Prevention counseling by pediatrician, poison control. In Sweden, 1 Swedish crown invested in injury prevention could save 40 Swedish crown in healthcare costs. So it is incredibly important message for especially the decision makers to invest more in injury prevention, because injury prevention could be cost effective. And there are different intervention strategies, and it is quite famous, focusing on engineering, like product design, like car seats, play activities centers. Play activity centers, it is like baby walkers, but play activity stations or centers, they are not moving objects, so they are like much more safer for the kids than using baby walker. Environmental modification, like for example, here is this fences around the swimming pool or fences of the stairs. Here is the automatic mixing valve. It is prevention of the burns, especially in the households when the water heaters cannot be regulated how hot is the water. So educational approaches for individual behavioral change, like for example, use of bicycle helmet or safety, traffic safety education, and so on. Very important is enforcement. Legislation, if it is in the place, it should be enforced. Without enforcement, legislation will not work. In the UAE, we have the seatbelt legislation from the 90s, and when I arrived, still seatbelt use was very, very low. So only when the government decided to increase the fines and started to enforce the seatbelt use, the seatbelt use increased substantially. Now, if the question is passive or active protection, what works better? Passive protection, there is no requirement on effort by the individual. So, for example, there is fences around the swimming pool, or airbags in the cars, or the sprinklers, or fire alarm. So this is very important, and it is much more efficient than active protection. So in the example, like airbags or safety devices, and for the bunk bed, for example, that the children will not fall. Some other safety devices for the children safety. This guard for the window guard. It's for the doors that the children cannot open cabinet, for example, and to have the access to some poison. And they cannot, they are very curious kids, so they cannot open, there is some barrier to open the drawer, some for the stairs, for example. Here is very interesting gadget for the measuring the size of the toy. So the smaller toy is much more dangerous for asphyxia for the kids, so they could really choke. It is choking hazard, and this toy you can buy in some shops like IKEA or baby shop, for example. So it is very useful. Some electrical guards for stairs now for the oven, so that the child cannot open, and it is burn prevention. Automatic mixing valve, I was already speaking about that. Here in the UAE, we have many of the water heaters which you cannot establish now to regulate the water, so this is very useful. We have every year a couple of the kids who have the burns from the heaters, because in the pipeline the water is cooling down in the bathroom from the water heater, and then when they are opening the hot water, it is still cold water running. So, and then it is very hot wave with very hot water. So this causes prevention and some other. Example also from the UAE, it was camel riding related injuries among the children, because the kids were used as the jockeys for the camel riding until legislation was passed in 2005 and it stopped. So there was very interesting study by trauma surgeon who was doing study in a line focusing on these related injuries, and it was going to the zero hospitalization for the children due to the riding the camels. And as you see here, it was replaced by the robots. So now only robots are riding the camels in the UAE, and of course they have some like distance regulations, remote control. Active protection, it requires the effort. So there is some action by the human being. And this, unfortunately, it needs some awareness, it needs some individual education, it needs repetitive preventive maneuvers. It is not enough to have only posters that use seatbelts, right? So to increase the seatbelt use. So it is really challenging. I will have the example also about the bicycle helmets. We did some study, very interesting study in a line about the bicyclist behavior, and we found that only 2% of the bicyclists in the line were using bicycle helmets, and it is incredibly challenging, especially for the kids. Bicycle helmets are very efficient prevention for the head injury or brain injury. There are different studies related to it. So it is a very important issue. A couple of examples of the transfer of our research to the policy. We did a lot of traffic safety or traffic-related injuries research with my colleagues, Dr. Mohamed Sadiq from Department of Professor Fikri Abu Zidan. It was very interesting research. Recently with our PhD student, Dr. Prita, she did excellent research related to quadribike injuries in the desert. So of course, all these injuries, it is important to transfer to some action. So we had very good close collaboration with Department of Health, Health Authority Abu Dhabi and Abu Dhabi Public Health Center. So many of these messages were transferred to the awareness campaigns about the car seats, seatbelt use. Of course, government was using a lot of interventions related to traffic safety, police and so on. And the mortality decreased substantially. When I arrived, it was 32 per 100,000. It was in 2003, and now it is around 5 per 100,000. And it is one of the best figure from GCC countries. It is still double than in Sweden. In Sweden, they have 2.5, so we have the double mortality as Sweden, but still the progress is impressive. And some example from the child safety. With Safe Kids Worldwide, we did very interesting study in 2008 mapping the epidemiology of the or magnitude of the childhood injuries in the UAE, and we did some recommendation which was really followed by even the Congress of Arab children focusing on the child safety. Quite a lot of studies were transferred to the intervention for the parents and healthcare sector and so on. There are like really even changes in the regulation for the playground safety, for the shopping malls, for the schools and so on. This was like really quite example for transferring of the research to the health policy and action. And this was, I think, last my slide. So Aristotle, 2,400 years ago, he was mentioning, with regard to excellence, it is not enough to know, but we must try to have, and he was it. So thank you so much for your attention. Thank you.
Wonderful. What a wonderful presentation. Very comprehensive, very informative and illuminating. So thank you, Professor Michael Gribna. Such an illuminating talk. I think our participants who are listening to you and us right now from all over the world must be caught up with a lot of thoughts in their mind right now. And it's very clearly visible in the emojis which they are sending right now in honor of you. And so we shall proceed to have our panel discussion without any further delay, because we don't have a lot of time and we have an eminent professor joining so in the next session. Therefore, we have to go quickly to the panel discussion. I hope you're ready. Please take a moment to have some water and relax. And participants who want to contact Professor Gribna, he has put up his contact details here, and also he has put a brilliant quote for all of you. So you may note it down. It's coming from none other than Aristotle. Okay, so Professor Gribna, if you're ready, may I start the panel discussion? Okay.
Yes, of course. Yeah.
So there are a few questions I have noted down. I'll start with the first question. What role can public health professionals play in designing a national strategy for injury prevention in many fast developing countries like the UAE? And what can the Global South learn from countries like UAE?
It is very good and in fact very complex question. So I think it is very important that the injury prevention, it is multi-sectoral approach. So it is not only one sector. So I think it is very important to understand that there is important collaboration between different sectors. On a national level, I think it could be really owned by the, for example, health sector, but it is very important to collaborate with others. Now, it should be based, as I was mentioning, on the evidence. So it is very important important to have the proper data, access to the data and to assess the data, and only then to develop the intervention. World Health Organization is doing excellent job into providing the expertise. So there are like different guidelines and even the steps for the nations or the Ministry of Health how to do the injury prevention in proper steps. But first it is start with the data, proper data collection, assess the risk, and then to develop the intervention, but it should be multi-sectoral. Very important, maybe it is also community engagement, so this I was not mentioning, but to go down to the community, because many times a community has the answer. So I think this, for example, World Health Organization has safe community approach. It is based on the communities or, the cities or the villages. They could assess their risk and to do the even intervention on their level, local level, and to engage community in the intervention. I think it is also very important. I cannot hear you, Professor Satpathy.
Yes, sorry. I was on mute. Okay, excellent answer and very fast. In fact, I was not expecting. I was expecting that it will take a bit of time.
I can speak hours. I can speak hours.
I know. That's why.
I want
that's
to
what
give
I was
the
expecting.
possibility to others to other questions maybe.
Yes, definitely. Because looking at your stature and your experience, I was thinking like you'll probably go on for a long time. Because some of our past panelists, they used to speak for quite some time. Okay. The question number 2 is, how should public health professionals work with other medical and healthcare professionals, civil society, public policy makers, and community members for cross-sectoral integration and coordination for injury prevention in the global south? Our focus is on the global south, but you can draw on your experience in the UAE.
In fact, there is like, I will give you experience from the World Health Organization International Safe Community approach. And they have like experience from different countries, even the global south and developing countries and so on. And it is because injury prevention, if it is locally based, it doesn't require too much cost, so too much investment. In this case, it is raising awareness on the local level based on the municipality or villages. They could really map the situation, what is there. Always it is community assessment or assessment of the data. How is the situation? And then to raise this issue with the political support, because without political support there is very difficult to do any intervention on the local level or national level. There is still needed some political support. Then to raise this intersectoral collaboration, because I was mentioning, for example, traffic. Traffic you cannot do only in the health sector. It should be involved with the police. It should be involved even with the municipality and road safety design. There are many levels of intervention, which is very important. But again, the public or community could be really involved, even in designing the interventions. If it is, for example, school safety, like bullying prevention, for example. In this case, the safety environment could change not only from the regulation of the Ministry of Education, but it should be school level. So in this case, teachers, kids as victims, but also bullies and bystanders, and their parents. So there should be like really communication between them and all involvement focusing on this problem what they have. But these, different interventions or different injuries have different approaches. For example, child injury prevention should involve the parents and maids. For example, in the UAE, many families, they have the maids. So it is, again, very important somehow to raise the awareness about it and to do some prevention. We did some intervention, very interesting, here in the UAE with the home safety visits. And where we were, teaching the parents and showing the risk around the household and how to change them. Because again, if you are doing only awareness on the, for example, social media or TV, it will not reach completely down, because maybe somebody is not watching the TV or somebody doesn't have the access to the mobile phones or whatever. So there should be some like approach thinking how to approach the majority of the population at risk. So in the Czech Republic, for example, we are working with the Ministry of Health on the changing on national injury prevention policy, which was requiring also the healthcare providers to be involved in injury prevention. For example, pediatricians on the preventive visits, like when the parents are coming with the kids for the vaccination, for example, they already were receiving from pediatricians some safety messages according to the age of the child, because different age has different risks. So this was very important. So it is not easy answer, but this collaboration and communication between different sectors, between different levels of the society, and I think, for example, for violence prevention, the ecological model is very important. So there is, like, individual level, then it is relationship, community level, and then societal level for intervention. So all these levels are very important to have the more efficient intervention.
Definitely. I'll go quickly to the third question. How can the data-driven injury surveillance systems be implemented effectively in LMICs? Is there any potential role of artificial intelligence in achieving this goal?
Definitely, I think that it is really this very good question. And in fact, what we had the challenge here in the UAE, that there was not injury surveillance. When I arrived, it was only very locally based trauma registry. So the data were missing. We didn't know what is the situation. This is why even we were collaborating with Safe Kids Worldwide on mapping the situation. It was very challenging because the data systems were not accessible. They were not even complete. We didn't have the access to death notification report. So to map the situation, it is very challenging. Injury surveillance is incredibly important. Not all countries, they have injury surveillance or trauma registration. Again, trauma registration could be based on the hospitalized patients treated in the trauma centers, and injury surveillance, usually it is based on the treatment in emergency room visits. And even in the UAE, we don't have injury surveillance in all Emirates. It is only Abu Dhabi who has injury surveillance, because it needs some cost to introduce injury surveillance and to train the people, data collectors, and to assess quality. So it is not easy, easy task. So, but injury surveillance could be very important because it could feed the injury prevention efforts, and even mapping efficiency of the injury prevention effort. So it is very important. With the low cost, again, with many developing countries, I think that, for example, this community level could be very useful. If community can even map how many traffic-related crashes are there, how many school injuries or pediatric injuries, what is the problem with the drowning, for example, in the Bangladesh, it is very challenging issue with with the floods every year, and they were doing the colleagues in Dhaka incredible research and interventions related to the drowning prevention, training on the local communities, and to even to build quite ponds to change them to some very safe like pools, and teaching the trainers in the villages how to do the drowning prevention efforts, teaching the kids, for example, how to swim in the villages. So it was very useful.
Right. Definitely. Wonderful response to that. So let's go to the fourth question that we have here. What lessons can the South Asian countries like India, Bangladesh and all learn from UAE's model in road traffic injury reduction and emergency preparedness?
I think what is really quite impressive in the UAE, that it started to be supported by the government, the all injury or traffic safety issues. So it is taken into very serious consideration, because in fact in 2003 the UAE had the worst road traffic mortality in the world. 32 per 100,000. It is the number which was the worst in the world. And because of the effort of the government, intersectoral collaboration, road safety design, but also enforcement of the speed control, enforcement of the restraint use, introduction of the car seat legislation a couple years ago for the kids. So it was very useful. But enforcement was really, fines increased substantially. So the people who are driving, like, speeding, they feel it by the quite high fines. Introduction of the points, for example. So if you have only limited points, and if you are like, they are these black points, so then they will withdraw your driving license. The speed fines are connected to the car registration. So every year we have to register the car, and if you are not paying the fines, you cannot register your car. So there is some like really enforcement, and all this intersectoral collaboration was very successful. We have road designs are very sophisticated. So here, even in a line, some roads inside the city are like highways. So there's like 3 lanes in one direction, 3 lanes in other. So the psychology is that you can quite reach high speed, because between the roundabouts it could be 4 kilometers, but it is like highway and the people are trying to speed there. So you have to have the many radars, many speed control measures and enforcement, so to keep the people like really with the speeding could be controlled. Of course, the educational awareness campaigns are very important. Education in the schools about the traffic safety is also very important. In India, we had quite collaboration with New Delhi, and there is some incredible research what was done by Professor Dinesh Mohan and his colleagues with the road design changes, and many interventions were quite successful in India. Of course, there was some shift from the more motorcycles and bicycles to the more cars, and it is quite a fast shift of motorization, so increasing. But when you have the much bigger traffic, which is a lot of jams, so traffic speeding is less. So, for example, we had a quite interesting study, COVID influence in a line. And because of the pandemic, there were not so many cars on the road, so people were speeding more, and there was increase in the severity of the traffic-related injuries and deaths because of the speeding. So if you have too many motor vehicles or rickshaws or bicycles, there is big jam of the traffic and it is slower. So there is more severe traffic injuries. I don't know if I answered the question. What was asked?
Okay, right. So the next one is, yeah, you did. In fact, you did very well. In fact, right. Okay. So the next one is, do super specialty trauma care centers play an instrumental role in public health injury prevention, education, and health literacy? Would you like to explain their role and elaborate on that? What kind of experiences do you have in the context of UAE, and how would that be useful for countries like India and Bangladesh and other countries in Africa, let's say?
The trauma system is incredibly important. It's a more complex issue because it is including the healthcare facilities, trauma centers, type 1, type 2, type 3. This depends from how severe injuries, but it should be network. And of course, they are involved also in the trauma registry, collection of the data, but also intervention. So they are playing incredibly important role. The proper education of the healthcare workforce is also very important. And it costs a lot of money to build the proper trauma centers. The countries understand that if it is type 3, they cannot have too many. It depends from the geographic area to cover properly the area. But the trauma centers, for even accreditation, international accreditation or local accreditation, they require to have the trauma registration, which is very important to collection of the data, assessing the care, or trauma care, but also to do the injury prevention. This should be embedded in the trauma centers' proper function.
Okay, right. Thank you. The question number 7 is, how do you integrate the multidisciplinary team of rehabilitation specialists into the core medical domains and make the practice of injury prevention and intervention a true success story in all parts of the world? And what strategies would be useful in this regard?
I think it is very important, the health workforce is playing a major role in injury prevention. And we have different healthcare workforce. It is medically qualified and also not medically qualified. It is like in the public health, if you are thinking about the public health workforce, and for example, infectious disease control. or especially COVID pandemic was showing how important it is that we need to have the properly trained health workforce. The same is for the injuries. I think physiotherapists, for example, or the rehabilitation specialists are incredibly important because it is consequences from the injuries are quite severe. Now, because of the safety equipment and the cars equipment, we have the more survival of even serious traffic crashes. So, but there is this post-trauma care is incredibly important to then to transfer the people to decrease the disability and to bring them to proper function. So the collaboration between these health care workforce incredibly important by the surgeons, trauma surgeons, nurses, the physiotherapists and so on. Because now, before, when there was no trauma care on so high level, so there were much more mortality of the serious trauma. Now the more severe trauma are survival, but there is like really this post-traumatic care is incredibly important. Yeah.
Okay, thank you. The question number 8 is, how do community-based interventions compare with hospital-based approaches in reducing injury burden?
Again, this is very important. There are pro and cons for the different approaches. The hospital care is, or on the hospital-based intervention. And I will give you example here in the UAE, in Abu Dhabi Emirate, the Abu Dhabi Public Health Center trained and established some injury prevention centers at the hospitals and trained some nurses who are providing some messages about, for example, car safety seats, traffic safety for kids, but also about the home safety. But we need to think that not the access of the population, it is only those who are going to the hospital. So community intervention, it is based on the community needs and community mapping. So the best is combination of both approaches, that not only rely on the hospital-based intervention, but to combine this with the community and community engagement and community intervention. So this, I think it could be the best, to do, like we can call the bottom-up approach, a combination with a top-down approach from the national level through the hospitals and using hospitals as, intervention strategies in the, for example, injury prevention.
Right, thank you. Two more questions before we end the panel. What does the future of fall prevention look like, especially in a resource-constrained and increasingly graying world, and what can be done about it?
Yeah, no, this is very interesting question. It's very difficult to predict, right? With the technology development, and I could be optimistic, and I think with the development of technology, especially with driverless, for example, cars, in a couple of years, maybe we don't need to drive the car. There will be car technology, and they will drive without us. We will tell them go there, and it will drive us. So I assume that the technology could be very useful. The same is AI. We don't know where artificial intelligence will lead us. We are surprised by the speed of the use and expansion of the artificial intelligence. Look about the use of AI in the science or in research or in the education. ChatGPT is like taking the word in some way, right? So we are even have difficulties to cope with the speed of the technology involvement. And I think this technology in the injury prevention could be very positive. I'm quite optimistic, especially in the traffic safety, for example, if you can see that the cars start to communicate with each other. So they will, this technology will be implemented that, they will map the, and now it is like Google Map will show where is the traffic jam, right? But then the car will decide where to drive you the most safer and most fast way. Of course, there will be still some proportion of the human mistakes. So this it is very difficult to predict, but I'm quite optimistic about the technology development and the using of artificial intelligence and the improving the health safety and even in the treatment and so on. So I think it is quite interesting time we are living now in.
Right. So the last question, if we have to have an RTLS future, what systemic and infrastructural public policy measures would you suggest to the national and global bodies and policymakers?
I missed the first word. What, if we have what? Sorry, could you repeat the
If we
question?
have to have, yes, if we have to have a road traffic accident less future, what systemic and infrastructural public policy measures would you suggest to the national and global bodies and policymakers?
I think it is very important, communication and exchange experiences, because some country could be quite advanced, and it is like depends on the economy of the country. Now we see quite fast development in the technology and in the sharing the information and even technology. So it is quite fast changing the world. So I assume that this communication, even on the international level, and sharing the experiences, it is incredibly important. Transfer of the experiences from one country to another should be based on the local, culture and differences to assess this, how it could be implemented, because it can be not transferred without the proper mapping situation and assessment, how this new technology or new ideas or even safety features, how it could be transferred to the different countries. So I think the communication, exchange of information is incredibly important.
Right, excellent. So wonderful. So let me say a few words in your honor. Professor Michael Gribna, it is wonderful. It's very heartwarming, and we are immensely grateful that you came on a Sunday evening to spend with us and illuminate us with all your wisdom and profound wisdom and experience uh, in relation to the area of injury prevention and broadly public health and global health in general. It was a wonderful talk, and is very visible in terms of the emojis that you are receiving right now, that the participants are sending, and they have definitely enjoyed the talk. I would like to just say a few words that our Global Advanced Certification Program is one of the kind state-of-the-art program running right now, training more than 870 participants from all over the world, and international workshop series participants, altogether more than 2,000 participants, registrants at the moment, as on today, 6 p.m. Indian Standard Time. And our participants who are part of the Global Advanced Certification Program would receive a certificate with your signature on their higher education achievement statement. On that, your signature would be embossed, sir, as a tribute and an honor that you came here and you spared your valuable time to teach them. And all the resource persons who have come so far, by today, 15 resource persons from all over the world have come, and a few more to come in the next few weeks, and all their signatures will be printed on the certificate of all our participants. So our admin team would be in touch with you regarding that for your e-signature, and also the resource material, the PPT that you use for the lecture slide, because many participants actually request that, so we would love to have them. So please oblige. And we are not a very well-funded organization. We are a crowd-funded organization. It's a people's consortium. So therefore, we are not in a position to offer you anything physical as a souvenir, sir. But we are very happy to inform you that we would be very honored if you receive our certificate of appreciation, which will be sent to you in a few weeks' time. So with this, thank you so much. And if you want to have any parting words, yes.
Thank you so much,
say.
Professor Ratarin. Thank you for the invitation. It was a big pleasure. When I was reading about your activities, I really wish you luck, and it is really great activity. This is why I agreed even to participate. Wish you the luck and all the best, and all participants enjoyed the next presentation. And thank you for the invitation again. Thank you so much.
If you could spare a few minutes, please stay on board, because Professor Laron E. Nelson from Yale University joining us to give his interesting talk on HIV prevention. So he's already here, he's listening to us. So I without any further ado, I would like to please request Faisal, please do the last use before Professor Michael Gribna's talk ends and the next talk starts. We will not have a break because Professor has already joined, so we'll start immediately. Yes.
Sure. So thank you, Professor Satpathy and Professor Michel Gribna, for such compelling and enlightening discussion. So we will now move into our second panel discussion on of our today's session, that is using multi-level integrated strategies to tackle complex problems in HIV preventions. So our esteemed guest today is Professor Laron E. Nelson from Associate Dean of Global Health and Equity, Yale University, USA, scientist Lee Ka-shing Knowledge Institute, Toronto, Canada. So this session will be moderated by, once again, Professor Maheswar Satpathy, who is the founder and CEO of Global Alt and director of COE ECCPH, India. So Professor Satpathy, we welcome you once again to introduce Professor Laron E. Nelson and take us into the next conversation.
Yes,
Thank you.
definitely. Just give me a second. I'm writing. Okay. Right. Okay. So you're ready. Welcome, Laron. Wonderful to have you on the stage of Global Consortium of Global Health. It's so wonderful to see you, and we are very, very happy to have you. So let me do the honor of reading your bio. That is my job as the program organizer. So so happy to see your face and your smile, such beautiful smile. I'm sorry that it's a Sunday morning in US and we hassled you, but I hope our participants would enjoy all the wisdom that you have to offer, all this brilliant experience that you have. So without any further ado, let me read out the brilliant bio that is sitting in front of me. Professor Laron E. Nelson, PhD, RN, FNP, FNAP, FNYAM, FAAN, so many degrees and qualification, is the Independence Foundation Professor of Nursing and Associate Dean for Global Health and Equity. In addition, he is also serving on the Yale Institute of Global Health's Leadership Advisory Committee. He is also a scientist with the MAP Center for Urban Health Solution in the Lee Ka-shing Knowledge Institute at St. Michael's Hospital in Toronto. He is the inaugural holder on the Ontario HIV Treatment Network Research Chair in Implementation Science with Black communities in Canada. He has an impressive H-index of 32 and has a cumulative citations of 4,500. Professor Nelson is an elected fellow in the American Academy of Nursing. He has been honored by professional nursing organizations, including the Excellence in HIV Prevention Award by the Association of Nurses in AIDS Care and the President Trailblazer Award by the National Black Nurses Association. Professor Nelson was the first nurse to be named as one of Canada's rising stars in global health for his groundbreaking research in Ghana. His work in research and implementations spans multiple countries. He co-founded the Central and Africa Implementation Science Alliance, that is CAVISA, a collaboration of implementation scientists and implementing agencies from Cameroon, Congo, Ghana, and Nigeria, aim to improve HIV-related outcomes among adolescents in the region. He is also leading implementation science efforts to reduce racial disparities in HIV incidence, treatment, and viral suppression among African, Caribbean, and Black communities in Canada. His work in the US focuses on the use of multi-level, example social, structural, behavioral, and clinical interventions to reduce HIV infections among Black MSM. In addition, Professor Nelson also serves as an associate professor, associate faculty at Dalla Lena School of Public Health, University of Toronto, Toronto, Canada. Professor Nelson serves as a scientific advisory board member of Center of HIV Identification, Prevention and Treatment Services, CHIPS, UCLA, University of California, Los Angeles, LA, USA. Professor Nelson's research has been funded by the National Institute of Nursing Research, National Institute of Mental Health, Center of Disease Control and Prevention, CDC, Canadian Institute of Health Research, CIHR, Grand Challenges Canada, and the Ontario HIV Treatment Network. He is an associate editor for the Journal of Adolescent Health and an associate editor for the Global Health section of BMC Public Health. He also served as a guest editor for the Journal of Urban Health special issue on HIV and Black MSM. Research interests: Professor Nelson's domestic and international research investigates the implementation and effectiveness of multi-level intervention strategies to reduce race and sexuality-based disparities in HIV outcomes. He is recognized as the world's leading authority on the application of self-determination theory, SDT, for HIV prevention and care. His research also involves identifying interventions to address intersectional stigma at the organizational level and treating the traumatic effects of intersectional stigma that manifest at the individual level. Clinical practice, Professor Nelson is a public health nurse and family nurse practitioner licensed to practice with prescriptive privilege in the state of New York. So with this very humble and profound bio, may I request Professor Laroni Nelson, the Associate Dean of Yale University, to please illuminate us with his brilliant talk, and I am definitely looking forward to learn a lot and enjoy it. So the stage is all yours, Laron. Thank you.
Thank you for that introduction. It is my pleasure to be here with you today. I'm joining you from New Haven, Connecticut in the USA. So my talk, as you heard, will be focused on using multi-level integrated strategies to tackle complex problems, specifically focused on HIV prevention. So I'll start by something that I'm sure we all know, is that for most of the epidemic, behavioral science approaches have led the way, meaning that approaches that focus on individual level drivers or influences of HIV prevention were what we targeted our interventions to focus on. So these identify factors that were, either within us, intrapsychic, or intrapersonal factors, and in some ways, interpersonal factors, the factors between an individual and another individual. And there are models that we've used for a long time that have helped guide that work, such as the health belief model, the information, motivation, behavioral skills model. Those focus on individual level behaviors. And then there's others such as social cognitive theory and the relationship-oriented informational, motivational, behavioral skills model, which really did focus on factors between individuals. What you see on your screen is an intervention called HIP Teens, Health Improvement Project for Teens, which is a study that I was trained on. My PhD supervisor worked on this, and this was one that was developed using the information, motivation, and behavioral skills model. It was shown to be efficacious, and I show it as a way to say many of the gains that we've made in HIV prevention research have been because of what we've learned from behavioral science approaches. And these approaches are sort of grounded in this idea that there are factors that are modifiable, things that we can change. And historically, we've sort of understood those to be knowledge, people's attitudes, people's skills, and people's behaviors. And then we treated these other things as non-modifiable. So we didn't touch them because there's nothing we can do about them. We can't change social status. We can't change income, can't change race, can't do anything to modify gender. So we've sort of left those alone. But we've even come beyond that. And political determinants of health is one frame that has helped us better understand that there are things that we say are not modifiable, that we have to figure out how we change. Otherwise, we cannot change the trajectory of not only the HIV epidemic, but other inequities in healthcare. And so political determinants of health are policies and processes that outline the structure of the opportunities or limits for being able to have a healthy life. This could be, do you live in a place that has access to insurance coverage? Do you live in a place where your interactions with the police system can abridge your rights? You could be hurt, you could be killed. Do you have access to employment or housing? Can you vote? Do you have a say over your governance? If you're an immigrant in certain countries, you might not have access to those types of rights. And then to what degree can you exercise self-governance over medical decisions versus having these things legally imposed on you or somehow undermining your self-determination? So we would have said, in the behavioral sense, nothing we can do about that. Those are non-modifiable. Somebody else, that's not what we do. But we have to, because we understand that these are the larger drivers of health inequities. We've made more progress, though, in the social determinants of health. There's been much more an acceptance that these are things that we should be trying to impact. And so the social determinants, as we understand them, are the conditions and the environment where people live that influence their health and illness. Now, the social determinants are shaped by the political determinants. The political determinants set the structure, which then give way to the social determinants to either be supportive of people's health and living or that undermine them. So that shows up in how whether you live in poor quality housing, and whether or not that exposes people to chemicals or toxins in the air or in the building that might undermine asthma prevention, that might make kids sicker, or you drink water that is not healthy that makes you sicker, or your employment circumstances might cause you stress that impairs your immune function. If you're a person with HIV, that will be detrimental to you. Or if you have an incarceration history, that when you come home, that it limits your access to employment or housing opportunities, which might lead to increased risk of exposure to HIV through whatever you might have to do to support yourself. Now, in the original form, I shouldn't say that, in the behavioral science only approach, we sort of treated these as background information, right? This is your table one stuff. This is all the stuff that we know happens that we can do nothing about. So we acknowledge the presence of these determinants in our study populations as background information. But I would argue to you that we have not given sufficient attention to how they actually function. They're not just in the background. They're actually at work. That their function does things like distribute risk of exposure versus protection, who gets protected, who gets exposed, punishment versus impunity, who gets to escape punishment, privilege or oppression, urgency or apathy. We have to do something right now to stop this, or what's the rush? We can take our time. That the systems function in those ways that ensure that some people have healthier lives and that some people's health is undermined. And so this cube is showing that it doesn't actually just look like a cube just standing there, that it's actually moving. It is a system that is producing illness. It is producing inequities, and that we will not change that by just describing it. We will not change that by just focusing on behavioral issues and not attending to structural factors. That we have to have interventions that are designed to match the complexity of the system to address the structural violence that happens because these systems overexpose populations to risk and to illness. Even the idea of risk as a structural exposure. I mean, in the behavioral research, risk is sort of what a person did that increases their likelihood of something, versus risk can also be structurally exposed, that it might not matter what I do. It just matters. It may matter more how the system handles me, which could pre-expose me to risk or overexpose me to risk. So the idea I'm trying to make here is that this is not something in the background, that it's not just all around us. It's working. It's an active system. And we can't just treat it as a variable to be described. It has to be counteracted through intervention. So if we don't do that, if we don't find a way to counteract these, then the new innovation that we discover or that are discovered in health promotion and prevention will just produce inequities, because the benefits of these innovations will be differentially funneled to groups who are assigned to more privileged status, and they will be kept from groups who are assigned more marginalized status. The way that system is structured, it will funnel the benefit to groups and it will restrict them from others. So we can see an example of this from the HIV prevention world. This is just a graph that I've shown many times, and many of you may have seen it. It comes from data from the United States Center for Disease Control. And it shows different points along this timeline over a roughly 10-year period where we've had new, interesting, groundbreaking innovations. There was the HPTN study. HPTN is an acronym for HIV Prevention Trials Network. There was a study that showed that if you treat someone living with HIV and suppress their viral load, that you cannot transmit the virus. That was incredible, incredible discovery. Then we had the data from the IPREX trial, which showed that at that time, daily oral antiretroviral medication could also reduce the likelihood of transmitting HIV to another person during sex. We had other innovations in device technology, such as the ability to test oneself outside of a clinical setting. So all these things you might expect would improve HIV prevention for everybody, that it would mean we could get people treated, and if the virus cannot be transmitted, that the transmission rates would go down, that if we have these pre-exposure prophylaxis products, that transmission rates would go down. If people can know right away whether or not they have HIV because they can test at home, that they can get on treatment right away, or they can get on PrEP, all these things made sense that we would expect them. But what you see in this graph is that at every point that this new innovation was introduced, that the disparity, at least racial disparities, actually widened. If you see that the purple line is Black or African Americans, Black people, including African Americans, let me say that, and then the yellow line is white MSM, men who have sex with men. And that at every point that a new innovation was introduced, that the HIV incidence decreased in white MSM, and it has continued to decrease steadily and dramatically so. And that the purple line representing Black MSM hasn't really changed at all. It has changed somewhat, but not substantially so. And what you surely notice is that the disparity has widened as these new innovations have been introduced, not narrowed. And that is because of the structural issues that I talked about before, that as these new innovations come in, that the benefits are not accrued evenly across populations. They are accrued differentially to groups that occupy privileged status in society. In the US, the United States society is generally organized by race. In another society, it could be gender, it could be ethnicity, it could be class. Just in this particular example, it happens to be race. But the structures function quite the same way. And so what we understand then is that these structures function as a wall, represented by the wall in the picture, that actually block the ability for these efficacious biomedical interventions to actually make a difference on certain populations. And what we need, what we expect by designing multi-level integrated strategies is an effect that it punctures through that wall quite, and it has to be a pretty powerful punch to penetrate the wall, which is why the strategies can be complex and large in some ways, necessarily so, because the challenges is a complex, really tightly interwoven challenge. So where I hope the world is going, there's some evidence of this, is towards the use of multi-level integrated strategies, which are ways to combine interventions that optimize promotion, but also that the intervention is designed to meet the complexity of the challenge. Sometimes it's easier to test a simple intervention. I will give you that. Sometimes it's easier to get that funded because they're cheaper. I can give you that. And you can see whether or not the intervention works. You can test your hypothesis. Do you prove it? I could give you that. But the question that I am interested in, that I pose to you, is what difference will it make? And that's what we have to grapple with. An intervention that's simple, that's fundable, that you can test a hypothesis, has to have an impact in real life. And if the real life physical reality is complex and the intervention cannot meet that complexity, we've not done anything but design an intervention and tested it and showed that it can work in theory, but in reality cannot actually do anything to change the course of some of these problems that we face. So one example I give, one of three, is a study that I helped lead called HPTN-073. This was a study of an intervention that I designed called Client-Centered Care Coordination to see whether or not we could improve rates of PrEP use and adherence among Black men who have sex with men in the United States. So this, as you heard from my bio, I think a lot about self-determination and the theory underlying it. Something I learned in my training, and it sort of stuck with me ever since then. But it's based on these three components, which is that humans in general have these basic psychological needs. One is for autonomy, for freedom, the need to feel that you have total control or enough control over what happens to you, over the choices that you make. A need for competence, that you feel that you have what you need to master whatever goal that you've set for yourself. And relatedness, which is that you feel connected to other humans, particularly if it's a human that is giving you health advice, that you have to feel that there's support supportive, caring people in your atmosphere who are supporting you in doing this. And so in this intervention, we design it to work with healthcare workers on how to promote these three elements of human psychological needs: autonomy, competence, and relatedness. And we tested this model. We tested this model, which was if we could support people's autonomy. Autonomy support includes both the relatedness and the competence that I just showed you. That supporting people's autonomy would satisfy these basic psychological needs, which would then increase their ability to self-regulate their decisions and their behavior around PrEP, that it could increase their perception of how confident they were that they could accomplish their goals around PrEP, and that would increase PrEP use behavior in a sample of Black MSM. This was an interdisciplinary study, actually. It was led by Dr. Darrell Wheeler, who is the president of a university right now, his background is in social work, and also Dr. Sheldon Fields, who's a nurse like me. So this is what we tested in the sample. And so what you see here is a result of a structural equation model. And I should back up. The key to this is that those intervention components were not, we didn't train Black MSM on this. We trained the healthcare providers on this. So our intervention was actually targeted to the system, not to the individual. Again, we said the system needs to treat the people differently. If the system is intervened upon and understands a different way to engage and support the men, we can see those changes. So it was targeting the system level and getting the system to target individuals, the behaviors of individuals at that level, where we thought we would see the changes. And so we tested that through a structural equation model, and we found that by using this model, it accounted for over half the variance in PrEP use levels among Black MSM. And we define this as therapeutic PrEP levels, which is, we didn't just ask them, are you using PrEP? How often are you using it? We tested it. We took blood samples, dry blood spot samples, to understand the degree to which people had evidence, biomarker evidence of PrEP use in their blood. So we know that this theory, if you can support people's autonomy, if you can train healthcare systems to act in particular ways, that the men under their care would actually use PrEP and adhere to PrEP at much higher rates than folks who were not operating this way. Another part of this is the care coordination. So again, this is why the multi-level part is important. Part of the intervention focuses on goal setting, having people understand they don't have to set goals, but if they set a goal, that autonomy support can advance those goal setting, and that they can make progress towards those goals, and that if they make progress towards those goals, they'd be more likely to adhere to PrEP. But what we also said is, it's not just do they set a goal. That is still a very individual, behavioral focused variable, goal setting. We said the systems that they need to rely on to accomplish those goals have to also be organized. And so we also want to look at care coordination quality. Does the quality of care coordination, the quality of the ability of an individual or organization to ensure that the multiple services that you need are aligned and communicating effectively, does it have an effect on whether or not you make progress towards the goal that you set, and whether your goals progress influences whether you adhere to PrEP. And we found that, certainly. So again, this is multi-level: goal setting at the individual level, care coordination at the systems level. So we found that the quality of care coordination, if it was high quality, it actually enhanced the association between setting a prevention goal and progressing on that goal. And that quality care coordination also enhanced the association between the prevention goal, progress, and PrEP adherence. So you could make progress. If you set a goal, you can make progress on it. And if you made progress, you could probably more likely adhere to PrEP. But if your care was coordinated better, you could really make substantial progress in both these areas. So again, making the case for why multi-level approaches are key, because the issue of PrEP non-adherence wasn't just whether I wanted to do it or not. It was often sometimes things in the environment, such as housing or employment or legal issues. The next one I'll talk about is a study we recently completed in Ghana. This is a randomized controlled trial that I led with Dr. Lauren Nyblade of RTI International. I just call it PRISM for short because it's a long name to show. So what we found is that in Ghana, this stigma operated at multiple levels: community level, institutional level, the level of peers, your friends, and the level of family. And then you can see on the left-hand side of your screen the particular manifestations that were happening: gossiping, verbal abuse, being non-judgmental, poor quality services. And so what this basically said to us was that we could do a simple intervention that addressed stigma at one level, let's say peers. But then that would ignore the other levels that were pretty significant, which were community and family and the institution. And the institution in particular, because this is where the individuals had to go to get the care they needed. In this case, we were looking at HIV testing. And so what we did is, again, designed another multi-level integrated strategy that looked at three levels. It looked at the institutional level. So we used an intervention called Health Policy Plus, which was a stigma reduction intervention that we modified to focus on intersectional stigma, which was not just HIV stigma. It was HIV stigma, it was sexual stigma, and it was stigma around people's gender nonconformity to perceived gender norms. So HP Plus was targeted towards the clinics. Then we took an intervention called Many Men, Many Voices, which we renamed Yantapo, which is a Ghanaian term, Ghanaian tree term. And that is a group level HIV prevention intervention that is targeted towards MSM, targeted towards the men. And that is about the relationships between the men themselves. And then the third level intervention was called Hive 3, which was intrapersonal. This is a truly behavioral one, which focused on how people dealt with stigma within themselves. So our goal was to do all three of these together at the same time, that we had to first reduce the stigma in the healthcare facilities, and then reduce the stigma that the men experience in their groups and within themselves. And then once we addressed those, we would have an interaction where they would all come together. And if we could do both those at those levels, we can increase the frequency of HIV testing among MSM after we reduce the stigma. And we found exactly what we thought we would find. And not in every instance, but in many instances. So this is just showing you the intervention effect on intersectional stigma reduction. The red line is our intervention clinics. There were 8 of them randomized to either the intervention group or the control group. This is in Kumasi, Ghana, and Accra, Ghana. So the red line is the intervention clinics, the blue line is the control clinics. So we found that after the intervention, that intersectional stigma reduced significantly in the intervention clinics, both at 3 months and 6 months compared to the control clinic. Even though, for some reason, the intervention clinics had more stigma at baseline than the control. We would expect this not to be the case because they were randomized. So you would expect stigma to be equivalent at baseline, but the intervention clinics had more stigma at baseline than the control clinics. But by the time the intervention was done, the intervention clinic faculty, the intervention clinic staff had less intersectional stigma compared to control clinics. We saw the same effect for subscales of intersectional stigma. This one was focused on gender and sexual norms, which are stigmatizing beliefs about gender and sexuality, that at 3 months and 6 months, the intervention facilities have much lower scores on gender and sexual norms stigma compared to the control facilities, even though there was higher stigma in those clinics at baseline, that we reduced that. If we look specifically at other elements, such as men who identified themselves as effeminate, they would say, I think the question was, when people look at me, do they consider you to be feminine or something like that? So because those men were much less likely to go to clinic anywhere because the risk to them were higher because there were these visible cues that made people believe that this is a person who's MSM, they could be stigmatized and they could be physically harmed or they could be treated badly. So if you look at this chart, it is showing you that at baseline, compared to men who were not feminine, that men who were feminine, only 20% of them were going to facilities for care, 20%. compared to almost 40% of men who said people don't see me as feminine. So the more masculine men were going to get care, treat services, the feminine men, less than 20% were going to get services. By the end of the intervention period, you could see that increasing by 3 months. And by 6 months, there were actually more men who identified themselves as feminine who were getting services at clinics compared to masculine men. So the masculine men number essentially didn't change at all. It remained around 40%. The men who were feminine, that number increased over 100%, from 20% to over 50%. So this is the power of multi-level integrated strategies. We could not have done that if we had just focused, if the intervention was just, let's have these group behavioral sessions and talk to the men about how to be strong about your health care and how to advocate for yourself. We could have done that. But if we sent them to a clinic that was stigmatizing, it would have backfired. So that's why we had to work with the men and the clinics, so that when the men were motivated and they were ready and they went to some place, that place was ready to receive them. So the multi-level component is key. The multi-level strategy is key. And the integrated nature of the strategy is key. They can't be separated. They have to somehow come together. And then the last point on this I'll just mention is we did see increases in HIV testing frequency at 3 months and 6 months in the intervention facilities, that the folks who were in those facilities had a higher odds of testing at 3 months, almost 6 times, and almost 10 times higher odds of testing at 6 months. So 6 times higher odds at 3 months and 10 times higher odds at 6 months. And this is relatively high frequency testing. This is essentially testing every 3 months, which is a lot more than what is recommended in some places. But because of these facilities changing that environment, that men were more likely to test there at a high frequency. Then the last study I'll mention to you is HP 10096. This is a current study in the United States in 4 communities, actually: Dallas, Texas, Montgomery, Miami, Florida, and Fort Lauderdale, Florida. So again, as sort of is the case that we talked about so far, this is another multi-level integrated strategy. It's a combination of interventions that addresses both structural issues, social issues, and behavioral issues, and we test them together. And let me this image is sort of a deliberate image because we had to explain this to people who are biomedical focused scientists, virologists, immunologists, who may not fully always appreciate social behavioral science. So we explain it this way in terms of like HIV antiretroviral medication, that the reason you have combination antiretroviral therapy in a pill perhaps is that there are multiple elements of the HIV life cycle that can be targeted. That you could do one active ingredient that focuses on one part of the life cycle, but there are other parts of the HIV virus that can still perpetuate the virus. So you use multiple components to attack multiple elements of that life cycle. Because when you attack multiple levels of that life cycle, you make it more likely that you can stop the virus from replicating, right? That's what we're doing here. That you could just do behavioral, or you could just do social, or you could just do structural. But it's not just behavioral, and it's not just structural, and it's not just social. That by attacking multiple elements of this cycle, if you will, you make it more likely to actually address these inequities. And so that's what we've done. And actually, all the examples that I've given you so far, that's the logic behind it. And so this integrated strategy has multiple levels. We hypothesized that if we do this, that we can increase multi-level social support, reduce intersectional stigma in facilities, and reduce structural barriers, that can increase people's individual agency, the feeling that they can actually accomplish something, and that will increase their enrollment in a clinic for health services, that they will increase HIV testing, that if they're living with HIV, we can increase their retention and care, and if they don't have HIV, that we can increase their PrEP use. This is another representation of that study. Our outcomes are PrEP prescriptions. Can we increase those? Can we increase self-reported PrEP use? And ultimately, can we increase rates of viral suppression among the men who, when they test, they learn that they have HIV and getting them into care? This study, as I mentioned, is done in the US, in the South, in particular in the South, because the disparities are are quite extraordinary right now in this southern region of the U.S. It's the part of the country that has the largest proportion of Black people, and it represents the largest proportion of new HIV incidents in the United States. So we decided to focus there because, again, we're interested in having impact, not just whether or not this has efficacy, but can actually do something for the public. And that is our goal. And this is the design. It is not a randomized controlled trial. There are challenges with trying to do that, but it is an interrupted time series, which is we will measure 2 years back from the point that the intervention is introduced, so that any baseline improvements that might be happening can already be captured in that look back of 2 years. And that we expect that from the time we introduce our intervention, that the trajectory of any baseline improvements would change dramatically. And that would be, we would conclude that that is the result of the introduction of the intervention at that time point. So that is how we're looking at it. And then I'll end by saying this, that when I started by talking on behavioral interventions, it was a way of what Thomas Kuhn, who was a historian actually, talked about in his book, The Structure of Scientific Revolutions, as normal science. It's kind of the way we do things. It's the status quo. Everybody knows how to do it. You get trained in it, you get good at it, and you just kind of do it that way. But then there comes a point where you have to ask, or what scientists ask, is the science addressing the problem of society sufficiently? And then other folks, new young people are usually the ones who are doing it, start thinking differently about it. Why are we doing it this way? It's not actually changing the curve. The lines are getting further apart, not closer together. Something has to be done. And that signals an entry into a scientific crisis. And that can lead away to a scientific revolution, a new way of doing things, sometimes dramatically so, and then a paradigm shift. And what I propose to you is that we've already been in a scientific crisis for quite some time, and that this multi-level integrated strategy approach, addressing things that we said could not be addressed, trying to modify things that we said were non-modifiable, is the revolution and the paradigm shift that I hope continues to spread around the world as folks realize that structural changes need to be made for us to tackle these health inequities, including HIV. So thank you, and look forward to our discussion.
What a wonderful presentation. Heavy with research and lots of insights. So I'm sure our participants enjoyed all the brilliant insights that you had to say. Now, few more. Okay, yes, it's very much substantiated by the kind of emojis you are receiving, all with hearts and bridges. So it's brilliant. So if you're ready, Laron, can we proceed with the, yeah, okay, right. So I have a lot of questions for you. So I hope you're ready. Question number 1. How can we better engage marginalized communities, example, the LGBTQI community, which is your core area of research, and the sex workers and the IDUs, that is injecting drug users, because they often co-present with each other, in the design and implementation of SIP research and interventions in the US as well as outside the US, because we have a global population, so we have to also take into consideration their interests.
Yeah, thank you. I think we obviously we must do that. In my case, I would suggest that I think maybe there's an early answer, which is how we train scientists. I think that we have, as when we train scientists, we have to train them to understand that we have to design interventions in collaboration with communities, co-design them, particularly with the people that we say we're going to intervene on behalf of, that they should have some say in what it is we think we're going to do and why we're going to do it and whether or not that works. And we're not all scientists aren't always trained to think in that way. We see ourselves as helpers, not necessarily collaborators. And it's important that we see communities not just as people to be helped, but people who have solutions and ideas that we must figure out how to incorporate into the work that we do. That's what I've tried to do and I'm trying to do, but I think part of it is doing that. And then, if scientists appreciate that, healthcare providers appreciate that, then I think finding ways in your budget allocations to finance that participation. It's easy to ask people to volunteer to do it, but communities are managing the same way we're managing. And that if they're going to contribute to the work that we're being compensated to do, they should also be compensated to do it. And I think that forces a scientific community to really think about how it manages its resources. But it can be done. It's just we've not really had to contend with it. And I think if we are forced to, we'll find ways to make sure that we can finance the kind of participation that is necessary to make sure the intervention is the right one to do, that it's the right intervention for the right question, for the right people at the right time, than just our interesting ideas that we come up with that we decide to test whether or not anybody cares about it or needs it or not, particularly with injection drug users or sex workers, because you really can't theorize what that experience is if you've not actually lived it. And so the chance of getting it wrong is very high when I can't just sort of come up with what I think is the thing to do if I don't know how that feels.
During my PhD, because my PhD topic was purely focused on this population, LGBTQI, sex workers, and the drug users in India, you know. So one of the questions that was struck in my head all the time, and I was not able to get an answer. Even till now, I'm still grappling with that question. Like, what is the fair compensation? Who gets to decide it? And what kind of compensation structures can be actually adequately given to the population? Because at times what I notice is the population that we are studying, they're extremely sensitive in nature, highly socially disenfranchised. Many times most of the services may not be adequately available to them. So what kind of compensation structures can we actually devise so that they feel more engaged? Because at times money may be a motivator, but money may not be sufficient motivator as well. So how do we strike the balance is the question.
It's a good, let me think about this. I think, yeah, money is not the only thing, right? But I think it is a way to be fair that I'm getting paid for the work and you're making contribution and you're not. That may not always be possible, but I think it is fair to consider it and do it whenever it is feasible. To me, I have found that people have found value, not compensation, but value and participating in something that they think is going to do something that they care about. You don't have to care about research to participate in it, right? If I want to study whether or not this light on I have a new light device and I want to know whether or not it makes your pupils dilate. Maybe you don't care about that. You can still participate and not care. And in that case, you're probably gonna have to pay me something because I'm giving up time to do something that I care nothing about, that you're the only one who's going to benefit from it. But when we engage people in work that they care about, their investment is very different. And as a matter of fact, that's why many times they tell us what they want to do. Hey, Professor Nelson, we've been thinking about this. These are people who don't have PhDs. Some of them have never been to college, who say, we've been thinking about this and we got an idea. How come we're not doing it this way? And I go, oh, I don't know. Maybe we should, So can we test this? Can we do this? It's okay, yeah, we can do it. So I might not have money in that case to say, well, let me give you guys this money to help to work with me to do this. Maybe I do. Maybe I don't have enough for everybody. But they don't often require it because to them, they're saying, this guy is doing what we want, right? He's working for us in a sense.
Yes.
We don't know if this is going to work or not. We have to test it. But their investment is very different because this is something that they care about, that they value. So they already bring value to the enterprise. The problem, it doesn't always work that way. It's usually the researcher with the idea who has to sell it to the community. And if that's the situation you're in, again, you risk doing something that didn't come from the community idea. So it might be misaligned. And then you have to motivate them differently. But when the community has the idea and are engaging you as the partner, they're already motivated. They're already saying, this is what we want. We need somebody to believe us and believe in it and to help us know whether or not this can work or not, to validate that. That's what's worked for me in situations where many times I don't have a ton of resources to give, but it's not always been required because for the last maybe 10 years, my ideas have come from the community. And there's the limitless source of innovation that comes from there. So I would encourage people to really have authentic community partnerships where folks feel like they can share ideas to you and that you're not just pushing ideas to them.
Right, definitely. And one of my observations regarding the US research culture is like I feel the Black communities and the Latinos, the ethnic minority communities have far more solidarity with each other when it comes to doing research, community-based, community-driven research, compared to people if you're doing it on a general, let's say, the whites, other populations. That is a little bit of thing that is my observation, because I have a lot of friends who are doing similar things as you were doing, and I find that the community, the sense of community, the sense of solidarity among the Black community in particular is extremely high compared to other communities, and that is probably one of the reasons why money may not be a sufficient motivator among the Black and the Latina other communities, but maybe in other communities that might be a region. Maybe we should do a study. We should do a study later on to find out like what's the difference of motivations. Do they respond equally? You know? Yes.
You know, yeah, I think it's maybe it's, yeah, we could do a study on that. Let's talk about it. But it's solidarity and it's being organized. It's really understanding the value that you bring in the research enterprise, because we couldn't do this work without communities. We just couldn't do it. And they have to know that. And once they know that, then they know they have some cards to play. And that can be very, very powerful. I've seen a study. This was in South Africa. Maybe I shouldn't say the name of the study, but there was a study being proposed, and this was a room filled with mostly African women who, in the design of the trial, it was said that this is a new experimental product, but will also, since PrEP is on the market, folks will have access to PrEP. You know, they don't just have to take this experimental product and not be able to have access to PrEP that's available. They'll have access to PrEP that's available. So the women say, who's going to have access to PrEP? They say, oh, well, the women in the US and Europe, maybe it was just the US, because it's available in the US. And they said, well, why can't we have access to it in Africa? They said, well, it's not available. And they said, well, it should be. And they said, you know, that was a non-modifiable factor. We have no control over what governments decide to whatever. And they said, so you tested those medications here on us, on our communities, and then it's available there, and you're on to your next study, and the Americans who didn't participate in it have access to PrEP, and we don't get access to it because our governments didn't do. You have no stake in that whatsoever. You're just on to your next experiment. And so they stopped it. They said, we won't do it. We won't do it. And you better make it your responsibility to make sure we have access to it, or we won't participate in your study again for the Americans to get the benefits of it. And the scientists like, how is that our problem? What do we have to do with local legislation? But I will tell you this, by the end of that year, multiple countries had policies now that were about making sure that these women had access to PrEP. But it was because they understood that these people cannot do this study without us. And we could just say, okay, it's not your problem, we'll just do it. They said, no, we won't do it. And they just stopped. And the change happened. And that's what I mean by understanding value, and not just solidarity, but being organized, that we all have to say, none of us will do it unless they do what we need them to do for us. And it worked. And it can work many times over, but people just don't quite do it. But I think being organized, understanding your value, can really make sure that marginalized communities have a better say and more equity in that process.
Yes, I wish the same was the case in all other contexts as well, like in countries like India, Bangladesh, and elsewhere. But unfortunately, this is not the case, because a lot of participants actually report fatigue because they have been interviewed over time and time again, and nothing actually comes out. They don't receive any benefit, not financial, non-financial, nothing, neither financial nor non-financial. So it's just a wastage of their time, and unfortunately, that also leads to a little bit of kind of unfriendly attitude towards the researchers or NGO people whenever they visit. So they then start like, why have you come here? Because why are you asking the same questions each time? It's not actually helping us, whatever you're doing,
Yeah.
So they do understand, but they're not very organized. And that is one of the problems. Yes. So maybe we don't know that actually they're getting studied as a population, and then maybe
Exactly.
they should actually get organized. Okay, so I have lots of questions. I'll be very quick now. What
Okay.
role does intersectionality, that is race, gender, class? You talked about race, but I want you to focus more on intersectionality. Race, gender, and class play in advancing or hindering the HIV prevention efforts globally.
Yeah. I think in many, maybe in most places that uh it's people's understanding of this marginalization around sex. Sex as it applies to who's having it, how they're having it, and whether or not they should be. It shows up differently in different places, but I would say in general it marginalizes women. Women's sexuality is very heavily socially policed. And so I think it influences whether or not providers even talk to women about things like PrEP or prevention, especially if you're married or over a certain age. It just that belief about who you become as a woman of a certain age or type of sex you have has changed, and it influences the ways in which, again, people either facilitate access to prevention or they restrict it, even if they don't know that they're doing it consciously. That if you don't bring it up to me, if it's available, and I meet with you as my clinician, you don't bring it up, you decided not to make me aware of this. You've restricted my access to it. I think the same thing happens with MSM, for example, globally, that people's belief about the sex that folks have uh, and how they have it influences the degree to which they decide to make these products available to them or treat them in ways that mean they're never going to come back to your clinic or any clinic for that matter because they don't want to experience that negative attitude. And so I think class in many ways is a buffer that the more money you have, it does increase your access to these things because it reduces your vulnerability. Like I might say, yeah, I'm gay and I want PrEP. And I don't care what you say to me because you can't do anything to me because I'm wealthy or I have enough resources that you can't harm me in that way. So class can sometimes be a buffer to people. And folks who don't have resources, who have a lot to lose, can't take those risks because the risks are profound if they do. And so again, this is why because of intersectionality, the way we think about it, and these multiple areas that impact people, the multi-level strategies that are integrated are important because it's not just am I a woman, it's not just am I young or old, it's not just am I wealthy or not, or middle class or not, if I'm gay or straight. It's all of those things that happen with a person all at once, and we have to address those. It's complex, but life is complex, and so again, we just have to identify strategies that match the complexity.
So the third question to you, Laron, is how should the sensitive people of color and people with disabilities be reached out? And what's the most optimally suited mechanism to make the healthcare more accessible to all and as per their needs?
I have to think more about how to reach out to those folks, but to me, I mean, this is my own perspective. I think having routine, normal interactions and relationships are the important way to do it. If they only know you because you have a study going on, that's when you show up, it won't build authentic relationship. I think you have to really love the people that you work with. You have to be curious about them. You have to be interested in their life and what they do. And so there's no outreach. It's you're a part of that ecosystem. Uh, and we have to be honest with ourselves that we don't care about
But
them.
do you think all the academics, elite academics at top Western universities or even in Indian universities in our country are actually truly interested in the lives of people, the participants, the so-called participants?
Yes, I think sadly, no, I don't think they are. Um, But I think that's the way to do it, in a way that is sustainable. Is you can't just say, "How do I get to them?" Like you have to be with them. Then you don't have to ask the question at all because you're already in communication with them. One way that we've tried to do is build capacity within those very communities, disability community, sexual minority community, marginalized groups, because there's actually not a shortage of talent there, of intellect there. There's a shortage of opportunity. And so we try to design programs so that we don't have to say, how do I get somebody who has a chronic condition? How do I get with them? No, people with chronic conditions should be scientists. People who are gay should be scientists. People who are trans should be scientists. People with disabilities should be scientists. And so part of the goal has been to make sure that pathway includes all those people. So it's not just these sort of perceived normalized people reaching out to communities of people who they think need their help. Like we, I'm a product of that actually. Someone would say, "How do we reach Black people, Black queer people?" Like, and then some person said, "Why are we asking that question? How come Black queer people aren't the scientists doing the work? We should just invest in making sure that everybody has a chance to ask and investigate these questions with communities around the world, whether it's their own or others." So that might be the key, because I don't think you can convince people to care about the people that they study. You need more people that actually care about and are interested in the lives of the people that they study. And I think that comes with capacity building pipeline to make sure that we've trained them and resourced them to lead that work. And
Definitely. Definitely.
there was a
Yes,
second part
please.
of your question, which escaped me.
Okay, the second part was the disability, people with disabilities be reached out, and what's the most optimally suited mechanism to make healthcare more accessible to all and as per their needs?
Uh, well, I would say this is not a well thought out answer, but I think the business people, sort of hard to say that, but I think working with business thinkers about how to redesign the system. Uh, right now, governments are failing. They've not found smart, lean, efficient, cost-effective ways to do it. It's just getting bigger and slower and more costly, and it's making quality go down. And I think there are other innovators who aren't part of the conversation that we should bring in, so that they're thinking together with us. How do we do this? I mean, they call it in the business world disruptors, right? We've seen this in many examples of things that have been disrupted. Airbnb is disrupting the hotel industry. Netflix has disrupted the movie industry. All these folks who just thought about different ways to deliver what people want. And I think in healthcare, we've not really engaged with folks who can think about better ways to deliver what we want. We sort of relied on this old way of doing business. But I think it is to really have business innovators. They don't have to be CEOs of companies, but people who are thinking in enterprising entrepreneurial ways to connect with communities and find out what's a different way to do it. And then there is money out there that can finance these disruptions that can happen. But I think that's where those answers will come from, because it's clear that the way we're doing it now is not working for most people.
Okay, and the question number 4 to you is, what frameworks in your experience, because you talked about a lot of theories and a lot of models that are used in psychology in particular. I'm a psychologist by training. So what frameworks in your experience are the most effective methods to form multi-stakeholder collaboration when conducting community-driven research or prevention or intervention efforts?
I would say maybe there's two things. There's some empowerment frameworks that I think work really well. And like I think the one I'm thinking about is the health equity implementation framework, which is one I've used often. But I think the real key is to vet that in local communities, because many of these frameworks are general. And so there's some, they're mostly true in general, but the specific circumstance is very important. And so I think taking that to wherever you want to do the work and making sure it does just work for the community where I am. And if it doesn't, what do we need to change about it to make it really align with the reality of how things work on the ground? So it's not just here's the frameworks. I think the recipe is the best framework that you can imagine, and then really test that with the realities of life on the ground with people that you're trying to work with. I mean, that's really where you find out what's going to work in terms of how you engage. Because the way people, even in the US, a framework that will work in Savannah, Georgia, where I'm from in the South, may not work in New York City. Those are very different people. They're Americans, but they think about the world in very different ways. And so we'd have to make it work by really understanding what is life like in this place, and then using that to modify that theory, that framework, to make it make sense in that context. So if you can make that practice routine, I think it's hard to go wrong.
Yeah, I think the concept of equipoise, in real world is something which needs to be tested each time, because many times we clinical scientists or public health scientists often forget that in real world things work very differently
Yes.
than what the theories say, or whatever evidence says. In the age of evidence-based medicine, if we are talking about equipoise, I think we need to test theories based on the validity in real world in a particular context, attuned to a particular context and particular population once again. Because whatever, as you just said, in Savannah, Georgia, it may be applicable, but in Chicago may not, in New York may not, who knows?
Yeah.
Inside one country itself. Think about a country like India, where every 5 kilometers there is a new culture, new things. You are recently visited India, you have seen the diversity of India, right? So that's how it is. So how do we figure it out? How do we deal with it? I think the only way we deal with it is by understanding that things don't work the way it is told in books or in evidence or in
Yes.
the form of clinical research. Okay, so go quickly because I have lots of questions, and I need all the answers from you because I have got hold of you. So I need to get all the answers. So question number 5 is, what does a truly multi-level integrated strategy for HIV prevention look like? You already presented in the case of US, you have done some studies, but especially in LMICs, experiencing a disproportionately high burden of HIV infections and STIs. Because you have some studies in Ghana, I would like you to expand more from Ghana to everywhere. Say, talk about all LMICs. What sort of, like, let's think like we want to create a multi-level strategy for everywhere, all LMICs. What do we do?
I think that, so again, definitely start with community. And to me, is you would just think about what's the problem we're trying to solve here, and what are all the elements that are contributing to the problem, and how might we address as many of these elements as we can to address the problem. Usually, you say, "What's the problem? What are all the elements?" And then let's focus on this one. All right, that's typically how it goes. And they don't have to be complicated elements, but it usually is not just one. And I think you have to say, what are the multiple ones we can work on? Maybe that's 2, maybe it's 3, maybe it's 5. But that, to me, that is the approach. In the case of Ghana, it was, we got to focus on how men see themselves in groups, how the groups interact. We have to focus on the fact that these individual men start to believe the messages that they hear from their parents, from the church, from the mosque, from wherever, and that the healthcare providers also believe this and they create these environments. So we had 3. We could have had more than 3, but we thought, let's figure out a way to do these 3. But that exercise, what's the problem? What are the elements that are addressing this problem? Just lay them all out and then think about which ones can we address and how might we do them together in an integrated way. I think you can do that every time in every country, because it doesn't have to be a healthcare facility. It doesn't have to be stigma if the healthcare facility is not the issue or stigma is not the issue. But the goal is to figure out what are the elements contributing to the problem and what might we do to address it. And then sometimes you can test it on a smaller scale. I mean, the the part that I think is most daunting about what I presented is that I presented big studies. Like, how are we going to do these big studies? Where's this money going to come from? But they don't have to be big to start. Like, if you can figure out what that is, like, you can do a small test of it to see, were these the right elements that we decide to pick? Maybe they don't really impact as much as we think they do. That's why the research is important. But you can do these things on small tests and then think about how might we, maybe you don't even do larger tests. Maybe you move from the smaller testing to medium to sort of implementation, just sort of evaluating as you go along. But that's how we, even in Ghana, we've done that because we didn't always have money to do it. And the political situation wasn't always such that we could do it big anyway. So we had to figure out what we can do safely and feasibly. And then once we figured that out, we said, okay, now let's get larger. But it's not as complicated as I maybe made it sound, but the complex part is the mindset that just getting out of just the behavior only approach. If you can do that, you've done most of the work, that you consider that we can do more than what we typically do.
Definitely. Okay, so I have 5 more questions for you, Laron. So please
I'll go
tighten your
fast.
belt. Yes. So question number 6. In the age of artificial intelligence and increased focus on non-communicable diseases, why is HIV and STI prevention important and still remains relevant? What is your advice to the national and regional health systems such as Africa CDC and SafetyNet, South Asian Field Epidemiology and Technology Network?
I mean, I think they're still important regardless of the AI and digital technology. I think they offer us new opportunities to have solutions that are less labor intensive and maybe more efficient to address those issues. I would get my advice to the CDC, Africa CDC, or other organizations would be to have communities, sex workers, MSM, whoever you're trying to address this with, think with you about how best to leverage that technology. Make sure they can understand the possibilities of it. Or even if they don't, they might have wild fantasy ideas that we thought could never be possible. But with AI, it actually might be possible. So I would say engage in ideas that seem out of this world, and then figure out how to leverage AI to figure out how we can actually make those things reality.
The second, how do we make the insights and principles of behavioral science? I know that you try to cover a bit, but I want you to expand on that. How do we make the insights and principles of behavioral science and social sciences relevant to improving global health worldwide and with a focus on HIV and STI prevention in particular?
Ask the first part of that question one more time.
How do we make the insights and principles of behavioral science and social science relevant to improving global health worldwide?
I would say just to think about the idea that we live in a social world and that our behavior is not just a function of what we think, that it's influenced by what we learn and what others around us do or don't do. And that we have to keep that in mind as we design solutions. If we design solutions for a child, for example, an adolescent, that does not take into account that this person may be influenced by their parents or their friends or their teacher or whatever it might be, or that where they live, how far they are from their school, that its effect will be limited. So as we design interventions to be implemented, I think we have to think also about behavior. Much of this is enacted through individual behaviors, but that behavior doesn't happen in isolation. And so I think if you think broadly in that way, you can help ensure that behavioral interventions or behavioral targets can also take into account the people's social influences, especially now where those social influences are even more complex with social media, people's access to internet and online, that you really can't do behavioral work without thinking about the social world. It's harder to do that now. Less credible.
Definitely, I agree completely. Okay, question number 8 for you is associated with something which you just spoke about, but I would like to emphasize on this particular question and maybe address this. This is a very important question actually, because when I was drafting it, I was thinking like, how is he going to address this? I know you will be you're more than well qualified to answer this. So question is, what would a multi-complex intervention look like if it aims to address the complex issues and barriers of long-standing and deeply entrenched inequality and inequities in our global societies?
Well, I mean, that's a very tough, serious question. I think if I was sort of to take that to its fullest extent, I would say it would be policy changes. I mean, we didn't really get into policy here, but it would be changing the ways in which elements of the society is structured. And hopefully those can be done in ways that are non-violent. Uh, but I mean, it would be severe disruption. It would be overturning things that have been entrenched for a long time. But I think once people realize that some of these systems are not working for them, they'll change. I think policymakers will see that the risk of leaving these systems in place are greater than the risk of changing them. And so some of that, people say, we were in a meeting recently where we talked about voting, and folks couldn't understand why are we talking about voting in the HIV prevention meeting. We're saying because the issues that you need addressed are not clinical issues, they're policy issues. And so unless you influence people who are making the policy, none of this clinical stuff is going to matter because the political determinants are driving this thing. And so maybe that is the answer to the question, is that the politics, it will look like political changes. That's what a true sort of larger multi-level intervention will look like. That's
And
harder to do, but yeah.
how do you see the concept of decolonization in this context? Because it's a fancy word of today's global health discourse.
Yeah. I mean, I think what I would say is it would look like communities deciding that they were going to do it themselves their way and finding ways to generate their own resources that don't depend on donors. I mean, that's a big challenge right now, is that globally, if you look at what happened to USAID, like a lot of the world depended on that, and they didn't have resources that they could control. And I think decolonization will be not just saying, oh, we lost this global money. It might be rejecting it and say, we don't want it. We don't want it with the strings. We have found a way to generate our own capital, and we will use it as best we see fit to address the needs the way we want to do it. That is decolonization. And then your governments have to protect you from that and not allow, because folks won't like it, or they'll want to come in and change the game. But to me, that's where I would see it. It's not something that can be given from the outside. It's something that has to be taken control of internally. And I think it could be done. That's part of what I hope we'll do in Ghana with the Ghanaian people, is let's figure out ways to generate capital and not have to worry about them.
Yes, definitely. Definitely. When all these funding cuts happened, there was a lot of discourse and a lot of debates on LinkedIn in particular. And I was on the other side of the entire thing, like talking about, no, we don't actually need it. Why are you pushing the idea that we have to go for the funding? Without funding, nothing can be done. I think we need to talk about whether actually people need it, and our people are in desperate need. And are people actually thinking of the idea of international aid as the most pressing need, without which they cannot operate, they cannot do anything? Why are you not pushing for ideas and policies wherein people can be more autonomous, can have increased agency and autonomy, and also self-governance, self-provenance? And that's something which I have been talking about and literally debating and fighting with people on LinkedIn and every forum, literally. But so far, not much benefit. Not many people are convinced.
Yeah.
The people have a particular mindset.
I'm convinced. I agree with you. Yeah.
Okay. In fact, the next question is related to that. How can the LMICs leverage global partnerships without becoming over-reliant on external donors and institutions? What is your word of advice in this inclement global funding climate in the recent past few months?
Yeah, I would say that LMIC, there's a lot of talent and a lot of innovation there. And I would say invest in it. I think we'd be surprised, maybe not, but be surprised at just how much value can be captured just within the country. I mean, I was just in India, like you said. It was extraordinary to see all the innovation that was happening there. And there are people there who are looking for ideas. And the ideas are not in the big companies. They're on the street. They're in the CBOs. Like they're thinking about all these ideas. I think if governments or LMICs invest in what's the talent locally, they won't need to rely on much else. I mean, in some ways, China has been an example of that, where they have pumped all their money into their people, and now they're forced because they didn't have access to global money for a very long time. So they just decided we're going to invest here. I mean, there are challenges for sure, but I think recognizing that the talent is not always on the other side of the ocean; it's at home. And there are ways that we can improve our lot by investing in local grown talent ideas.
Okay, I have the last question for you, Laron. Please have some water. It takes a bit of time. You have already spoken about innovation, so I would like you to answer that, because you said whenever innovation is sort of applied, it increases, widens the disparities, So the question that we have for you is, what emerging innovations in HIV prevention and care are showing the most promise in reducing inequities in health outcomes for the socially disenfranchised sections in lower middle income countries as well as in higher income countries like USA?
I think that, all the new PrEP products are pretty compelling. I mean, the injectables, I'm not sure how available they are, but they are compelling because they require less interaction with the healthcare system, which makes it easier for people to use. There's some that I think they're testing oral products, like monthly oral pill that's not in the sort of later phase trials, but I know that they're working on it. To me, so those are an ingredient of it. But I think care coordination models and online models that require less physical resources are going to be the things to help decrease inequities, because those models, this care coordination, really has a way to make sure that the resources are better aligned so that these medications can have the type of impact that we know they can have, but the social structural things get in the way. So to me, the biggest things that are going to decrease inequities are not more medications, because they're going to do what I mentioned before in the slide, just widen the disparities, but the different models of care. I think online models are going to be incredible. I think models that engage folks who are not necessarily physicians or nurses in providing the care, maybe even community workers. There was a model in DC where they trained peers. I don't know if they were sex workers or not, but they were peers who were trained to give injections. So they were delivering the PrEP by peers, because in some cases, peers inject each other anyway for other reasons, not related to PrEP. And so they knew how to do it, and they knew how to do it safely. And so that was a different model to actually deploy that, which was faster, it was less expensive, and people felt more comfortable with their peers who knew how to address them, who knew the particular anxieties. So to me, it's not the drugs that are going to do it, it's the models, innovations in the models of care that I think is going to help address these inequities.
So with this, the whole fire of questions gets to an end. So thank you so much, my dear Laron, for coming on the stage of Global Consortium of Global Health Activists, Leaders and Thinkers. Let me tell you, this is the only consortium as on today, which is the largest consortium on global health in the world, led by people in the Global South, having more than 2,000 members from 170 countries with proper documentation. So people have submitted their documentation to be members, they have applied to be members, not some list sub, nothing like that. We are not making those fraudulent claims as many other consortiums are making. And our consortium is run independently on crowd-funded basis. We have not received any funding from any bodies, and therefore this whatever we are doing for the past 8 weeks, this Global Advanced Certification Program and the International Workshop Series, which is delivering a service, all the knowledge and the training which is intensive research mentorship to our participants. More than 300 research students are learning with us and working on their group projects as well as individual projects at the moment. And we have 15 tutors, international as well as national tutors, who are delivering service. They are all doing this selflessly and altruistically. Nobody is receiving any funding, and we have not received any funding. So we take immense pride in that, and we like to mention it. But at the same time, this Zoom call, which is possible with the generous funding of one of my friends who is based in US right now. He's Indian, but he has requested not to mention his name. So I would not mention him due to all the new rules, regulations. So I don't want to mention him, but he's a very kind person that he supported our Zoom call, because this Zoom premium took quite a lot of struggle just to get it organized, because initially we were struggling for it. So Dr. Professor Laroni Nelson, with utmost gratitude and immense pride and privilege, this is my honor to thank you once again for coming on the stage of Global Consortium of Global Health Actors, Leaders and Thinkers, the Global Health Forum, the Global Brain and Mental Health Forum, and the Bangladesh Institute of Health and Innovative Research. Wants to thank you for your presence and for sharing this illuminating and brilliant presentation. I think I really enjoy interacting with you so much. I have learned so much, and our participants, I am sure, have learned so much, because look at the emojis which are flowing seamlessly. I don't think they would come like that, just like that, right? And after 1.5 hours of session, actually they have spent 3 hours now, still 200 people are on the call. And so that shows the level of interest and enthusiasm they have. And I would like to make it make an announcement, and please bring it to your record, that all the participants who are attending this Global Advanced Certification Program will receive a certificate of completion, and they will also receive a statement of higher education achievement, in which all the trainers and resource persons who come from any in the world, so far you are the 15th resource person coming from all different parts of the world. People, Malaysia, Singapore, US, UK, different countries have come, Australia, and you are the 15th person. All these peoples will be able to put their signatures on their certificate, so that it is a tribute. They will be able to claim that, yes, Professor Laroni Nelson has taught us in the future. Okay, you are one of their teachers now, you are one of their mentors. So our admin team would be in touch with you to get your e-signature, kindly oblige. And they will also request you regarding the lecture notes and any other material that you would like to share with our participants, so that they can be benefited. And I think this lecture would stay in their hearts and minds forever. And with this, I would like to thank you once again. I would now request Faisal to do the last use before you sign off. Faisal, please.
Thank you, sir. Thank you, Professor Laron Nelson, and our
Are you experiencing some issues?
speaker, Professor Michelle Grevner, and our host and moderator.
Okay. I can only see myself. Okay. It seems, yeah, Professor Laron has left. Okay. So no problem. Hazel, can you hear me? Hazel, there?
Hello, am I audible?
Yes, you are audible. Faisal, can you hear me?
Yeah.
Yes. Yes. Okay. You just lost your. Yeah. Professor Laron has left. He just sent a I'm leaving. So it's fine. We have already thanked him, and so no problem. So you can do the so do the last announcement.
To all our participants, your continued engagement drives the mission of this program. Let's carry forward this learning into action as we build a more inclusive, evidence-informed global health landscape. See you all in the next session. Until then, take care, keep growing, and good night.
Yes, and I would like to say, everyone, thank you for coming on board. We had a wonderful discussion. Still 187 participants are here. More than 3 hours have passed, and all of you have been a great audience. I love you all. You have been great. You have been very, very great. So that shows your level of commitment, shows the level of strength, shows your genuine curiosity to learn and do something great in the field of healthcare, global health. Okay, so you have been a wonderful audience. Please take care of yourself. Please fill today's attendance and feedback link because it will be closed in a few minutes. Okay, so please fill the attendance form. Do not send me a message saying like, sir, I could not fill the form. Okay, do not send that, please, because I'm facing a lot of challenges these days, responding to hundreds of messages daily. So please fill the form. Okay, and we'll definitely send you an attendance certificate, participation certificate in 5 working days. Okay, so with this, thank you so much. The meeting is officially over, and we had a wonderful time. Yes, you will get your the video has been live streamed on YouTube on the channel of Global Consortium of Global Health. You can have a watch if you want to watch the recording of the lecture. Besides, you can also download and watch it later on if you want to. You can download from YouTube link. I think that's possible. The attendance link is again shared in the chat, so please take time to fill it up, because without filling the attendance form, we will not be able to generate your certificate of participation. And for the GACP, Global Advanced Certification participants, please note that you will have to fill your attendance, because that counts towards your attendance to get your Global Advanced Certification in August. Okay, so please do not fill the International Workshop Series, because you are GACP participant, not International Workshop Series. So with this, thank you so much. Have a wonderful Sunday night. Eat well, sleep well, take care of yourself. God bless you. Take care. Bye. Okay, thank you everyone. You can open the chat now, Faisal, so that if anybody wants to say something, they can say. The chat is open now, Faisal, so people can put any comments. You can put all good comments. Please put good comments. Okay, we would love to hear your ideas. Okay, how you liked, how you enjoyed. Okay, yes. And those who filled the attendance last night, you will receive your certificate in 5 working days. Those who filled today's certificate, you will receive in next 5 working days. That means, okay. So you will definitely receive your certificates by the next Sunday, without fail. So do not message me saying like, sir, how many days will it take? It will definitely take 5 working days. Okay, that's the answer. Thank you. Take care of yourself, eat well, sleep well. Good sleep is very, very essential to do good work. Cluster number and working group number is not meant for International Workshop Series participants. That is, you can put as an NA, but for the GACP participant, it is compulsory. Okay, your 2 kinds of participants are attending this training. So yes, sir. Can you please put the YouTube channel link, Hazel? You should have put it. I hope you enjoyed the speeches. Somebody says you have lined up fantastic speakers. Definitely, these are world-leading speakers. These are not any ordinary speakers. GACP will be launched in a new format next time, but that will be paid. That will no longer be free. Thank you so much. Have a wonderful Sunday. I look forward to enjoying my Sunday. I hope you will enjoy yourselves as well. Thank you, Kanvi. Yes, YouTube link has been shared. Today's attendance link has been shared. Both the things have been shared. So please take care of yourself.